So I am delighted to introduce our moderator for our third and our final panel. And our moderator is Dr. Alan Brandt. Dr. Brandt is the Cass Professor of the History of Medicine and the Professor of the History of Science at Harvard University. And he was recently the interim chair of the Department of Global Health and Social Medicine at Harvard Medical School. Dr. Brandt is renowned for his work on the social and ethical aspects of health, disease, and medicine. He's written many books, including The Cigarette Century, which is an amazing history of the social and technical forces that shaped the rise and then the fall of cigarette use in the 20th century. It's also one of my favorite books. Dr. Brandt will lead our final panel, which is on the critical topic of implementation in precision medicine and artificial intelligence. Welcome, Dr. Brandt.
Thanks so much, Dr. Man Ray. It's great to be here. I've sat through today's meetings, and I've just been so impressed by all the speakers and the critical importance of the questions that have come up. And I expect we'll expand and develop some of the questions that have already come up in the panel that's about to occur. I couldn't help but think, as I was listening, about my excitement about the science. And this is a remarkable moment in the early 21st century when we have new capacity, innovations that could radically change human health, and many of them are in the areas of genomics, precision medicine, AI, and yet at the same time, it's an incredibly sobering moment for public health and medicine because some of the gaps and disparities in global health are actually growing as we have increasing capacity to do much more about it. And I think that underpins a lot of the questions that will come up on this panel. How do you implement? How do you take this science and put it into actionable practice that benefits human beings in a way that they have access and there's equity? And these are gigantic problems of our time, especially in such a divided political world where we have to talk about governments, we have to talk about capital and industry, we have to talk about expertise, and across this boundary, the history was often produce great knowledge and then figure out how someone will be able to use it effectively or for human welfare. But the linkage of those questions has never been more intense than now. And I'm incredibly pleased that we have a panel of people who have developed remarkable expertise in this area of implementation and thought deeply about how to turn our knowledge into practice in consequential ways. So let me briefly introduce the panel. On your right is Dr. Noah Dagan, and Dr. Dagan is the director of the AI-driven medicine program at Clalit Innovation in Israel, and that's part of the state's public interest in delivering healthcare to Israelis, one of 4 health services organizations. Next to Dr. Dagan is Professor Milind Tambay. He's a colleague of mine here at Harvard in computer science, and he's the principal scientist and director of AI for Social Good at Google Research. And finally, on your left, far left, is Dr. Paysan Ruamviboonsuk. And Dr. Ruamviboonsuk is the clinical professor of ophthalmology at the College of Medicine at Ranjit University in Bangkok, Thailand. And all 3 of them have had experience and examined the process of implementation. And I want to invite them to say a little bit about their work and what they've done, some of the possibilities that they see in effective implementation, and how they overcame some of the obstacles to the work that they do. So let me start with Dr. Dagan.
Thank you. Do we have the slides and a way to switch slides? All right. So as a short introduction for myself and I think the perspective I'll try to bring to this panel. So my name is Noah. My background, I'm a physician by training. I specialize in preventive medicine and public health. Thanks. And also completed my PhD in computer science, and I've been living between these worlds of medicine and data science for the past few years. I'm currently the director of AI-driven medicine in Clalit, which basically means that we are trying to provide very practical, very actionable insights to our physicians and to our patients. As just a few words about what is Clalit. So Clalit is the largest healthcare organization in Israel, one of 4 healthcare organizations, as was said. We cover over half of the Israeli population, almost 5 million patients. And we are both the payer and provider of services. So we have 14 hospitals and 1.5 thousand clinics that are spread throughout the country. And this organization is basically been around for over 100 years and has a lot of, I think, expertise that have accumulated throughout this time. And one major resource that we have is a very good and comprehensive data warehouse that basically has data of all facets of care and all aspects of things that happens to our patients. And we have these data both from the outpatient setting and from the inpatient setting, so we have the full continuum of care. And we've been digitalized for over 20 years with pretty low attrition rate every year, less than 2%, so that means that this very broad set of data is also very longitudinal in nature, so we have very good follow-up for our patients. And all of this data is collected and stored in a central data warehouse where everything is connected through unique identifiers. So all of the different data for a specific individual is connected. And my perspective, our perspective, is basically that we try to develop and deploy AI solution for the benefit of over half of the Israeli population. And one such solution that I'll give as an example, because actually it was developed as a direct consequence of one of the major gaps that we've encountered, is called CPI. So CPI is a patient management platform, and it stands for Clalit Proactive Preventive Interventions. Basically, what we try to do with this platform is 2 main things. One is to try to identify which patients we need to focus on proactively because they are at some high risk for any condition. That we do that through a series of machine learning prediction models and also some deep learning models when it comes to other types of data than structured data. And these series of models basically flag patients as high risk and introduce these patients as such to their PCPs so they can do something about that. And once the PCPs can focus on a specific patient, because we found that patient to be at a specific high risk for 1 or more conditions, then we try to provide decision support as to what to do with this patient through a series of personalized, very actionable recommendations, very detailed recommendations that we try to provide to almost to the extent that will be parallel to a consultation by an expert, a clinical expert for that specific condition. So just to put this into numbers, because I find it helps to convey the message. So for example, for one clinical module within this platform, specifically for diabetes, we try to provide recommendations for more than 300,000 patients. And these recommendations are basically based on 157 patient characteristics. So 157 data points that we need to curate from the raw data in order to make sure that we provide the most accurate clinical recommendation for this specific condition. And this is only for diabetes. This means that if a physician wants to know what's the most accurate thing to do with regards to a specific patient for diabetes, they need to collect this amount of data from the medical record so that they will have the full picture of everything they need to know that might affect their decision. And these patient characteristics basically are used to produce 384 distinct kind of clinical recommendations. So you can imagine anything that we might want to say about the treatment of diabetes to a physician. That will mean the full complexity of all of the dozens options of medications that we currently have for diabetes. It will be all of the lab work that this patient should perform, all of the different follow-up appointments, all of the different workup that should happen on a regular basis. And I think these numbers basically convey one of the big challenges that we encounter when we want to aid medical decision-making, and we want to augment that with insights from data and from AI, is that medicine is complex. It's a lot of data and it's a lot of decisions, and to try to augment that in a very accurate kind of way, in the right point in time, and in the right point in the point of care, which will be useful for physicians, is a big challenge. This module in CPI for diabetes basically produces almost 9 million recommendations, personalized, actionable recommendations every night for our patients. And this is one module, and we have several modules, but one of the big gaps in care is the fact that this is complex, and this is what it entails to do it for one clinical condition. Now we want to do it for many conditions to basically cover most of the chronic conditions that we need to face when treating our patients. And I'll just say as a brief, I think first insight in this discussion is that the fact that this platform was born is for a big challenge that we had when we tried to basically reinvent the wheel every time we had an insight from data or from AI. It could be also from precision medicine. It could be for I don't know, pharmacogenomics or whatever insight that we have, that we know something about a patient, and we want to convey that knowledge to the person who's currently treating that patient. And we found that we are trying to reinvent the wheel every time for each project, for each clinical insight that we had. And the first thing we tried to understand and how to progress from that very frustrating point of taking years to introduce each such insight into the point of care is to basically create this system, this platform that is very general in nature, so that no matter what insight was born and from which kind of data, from imaging data through image analysis, or from genomic sequencing, or from monitoring data, or from EHR data, we can introduce this information into something that is already integrated into the electronic health record in a very general kind of way that will suit any kind of data and any kind of insight that might be born in the future. This is one thing that we are doing to tackle this deployment challenge. I would say that this platform is currently deployed for, as of yesterday's morning, 1,486 PCPs in Clalit. It's about 50% of our PCPs, and this number is growing by the week. But I'll just say that solving one problem and bringing this platform into the point of care basically opened 10 other challenges that now we need to face, and I'm looking forward to discussing these in the panel.
Thanks so much. Dr. Tambay.
Yeah, so my story is that about until 17 years ago, my lab and we were focused on methodological AI research, but about 17 years ago, I decided to focus on this idea of AI for social good, and realizing that social impact and AI innovation go hand in hand. So with respect to public health, we have large populations to serve, but limited number of public health resources. So concrete example is work we've done with youth experiencing homelessness in Los Angeles. So harnessing the social networks of these youth, we are able to show that our influence maximization algorithms are far more effective in reducing HIV risk behaviors compared to traditional approaches. But this work required innovation in the area of influence maximization in social networks, because the networks themselves are not given to us. So how do you sample those networks efficiently? But We have also been working prior to that in other areas with respect to conservation. We have large conservation areas to protect limited number of ranger resources. Concrete example is work we've done with Uganda and Cambodia. We're harnessing past poaching data. We are able to predict where poachers set traps or snares, and for the past several years have been able to remove thousands or tens of thousands of these snares. This work required innovation in the area of what we call green security games, which combines machine learning and game theory. All of this work came about because of a previous work we did in public safety and security. We've contributed new algorithms in what we call Stackelberg security games to design algorithms for the Federal Air Marshals. So if you've been on a US air carrier, United, Delta, et cetera, whether there was an air marshal or not on your flight in an international flight, may have been our algorithm, or deciding patrol patterns for the US Coast Guard in the ports of Boston, New York, Los Angeles, and others. So these may seem like very different areas, but they're all connected together. First of all, these are long-term commitments of mine and my students, and all of these are connected together because the underlying algorithms are all the same. Today, though, I'm going to focus on the work that we've been doing for the past several years. We've been, with the introduction that we got to maternal mortality crisis, this idea that the UN Sustainable Development Target of maternal mortality ratio, mothers dying near childbirth or right after, should be below 70 per 100,000 live births. So we've been very fortunate to work with a nonprofit called Arman in India, which works with the world's two largest mobile maternal and child care programs. So these are programs where the mothers enroll and they get a call once a week informing them about breastfeeding or taking iron pills or whatever it is that needs to be done according. And so the calls come in the local language or automated voice calls. And so one of their programs is called Mitra, which is about 200,000 mothers enrolled at a time. There's a national program from Government of India that they also manage, which is called Kilkari, which has 3 million mothers enrolled at a time. And they've shown in randomized control trials that mothers who listen to these voice calls in a regular way benefit significantly in terms of their own health and the health of the babies. So where do we come in? The challenge that's faced is that 30 to 40% of the mothers enroll and then drop out of the program. So then the question becomes, how can we use AI to optimize their limited intervention resources? For example, for M-Mitra, they have this call center from where limited number of calls can go out to a limited number of beneficiaries. So these are human callers calling these mothers to encourage them to remain in the program. But the question is, who do you send these calls to? Who do you target? And that's where AI can help in figuring out who are the right people to call at this time to stop them from dropping out of the program. And so we have applied an AI restless bandit models. This is basically some kind of reinforcement learning for those who may be familiar. We did a field study with 23,000 beneficiaries, one of several studies that we've done. So I just wanted to quickly tell you this 7,000 beneficiaries per group. We called 225, that's pulling 225 arms per week for 7 weeks. And how many more messages were listened to compared to the current standard of care, showing that the AI group benefited significantly from our targeted AI interventions. So what's happened since then, we've built a system that's deployed with Arman for this M-Mitra. Since April of 22, it has served about 280,000 beneficiaries. And we can show by various sampling that the restless bandit cuts the drop-off rate by 30% over what is the current standard of care. Our next step is to move to this Kilkari program, which is much, much larger, more than 10 times larger than this M-Mitra program, which is a national program, which is bringing up all kinds of interesting challenges. So this hopefully gives you a flavor of the kind of work that I and my research group are engaged in. We are always focused on end-to-end systems that get deployed in the field and understanding all the challenges that arise from data to deployment. Thank you.
Thanks so much. Dr. Ruam Vibhunsek, please.
Thank you, Alan, for the kind introduction. Well, my name is Dr. Paisan from Bangkok, Thailand. I'm a retinal specialist. Retina means it's like a film, the camera is at the back of your eyes. So we have a lot of disease in the retina. Well, I was trained for retinal disease at the Albert Einstein College of Medicine, Montefiore Medical Center in New York back in 1994, 1995. And I went back to Thailand to work in a large teaching hospital under the Ministry of Public Health back then. Retinal disease include like retinal detachment, which you have to do the surgery, or macular degeneration, which you have to do like intravitreal injection, or especially diabetic retinopathy. Well, I was doing a lot of surgery for diabetic retinopathy, especially for traction retinal detachment from diabetic retinopathy. You can do surgery, but patients cannot see well. You can do the surgery, but the patient is getting blind after the surgery. So I figured out, well, the best thing to treat patients, especially with diabetes, especially diabetic retinopathy, is not treating, but prevention. And this is the slide is importance of diabetic retinopathy. You can see that, well, diabetic retinopathy is a kind of like major eye disease of diabetic patients, and it's also a leading cause of blindness for working population for the whole world, in the US and also in Thailand as well. And globally, the number of patients with diabetes is kind of increasing. We may have like 190 million people by the year 2030, and the number of sight-threatening diabetic retinopathy kind of increased to be maybe 56 million people by the year 2030. And the way of prevention blindness for diabetic retinopathy is quite easy. Just taking photographs of retina is a recommendation by the American Diabetes Association and the International Council of Ophthalmology. If you have diabetes, you need to have eye examination at least once a year. And the upper image is normal retina when you don't have any retinopathy. And the lower part is the diabetic retinopathy. You can see it's obviously that you can tell the difference between normal retina and diabetic retinopathy. And well, the key of detecting this disease, maybe just take retinal photos, and you maybe teach someone to read the real images to detect those cases for referral to see ophthalmologists. And we keep doing this in Thailand since 2013. Well, and the upper part is what we are doing since 2013. We bring the retinal cameras to communities. We do the screening in community hospitals throughout Thailand. However, we train the personnel who's not even like doctors. They are nurses, they are technicians. We train them to be able to detect diabetic retinopathy for referral, for treatment, for timely treatment at tertiary care centers. Actually, we try to keep them to be able to detect diabetic retinopathy for referral with the accuracy like 85%. Sensitivity that I wrote there is 75%, but the specificity is quite good, it's around 98%. We keep doing this for many, many years. And then recently, in the year 2016, we came across with a paper published in JAMA by the Google Group. They used their AI for detecting diabetic retinopathy for referrals with the accuracy of 95%. The sensitivity from that paper is like 95%, and specificity is also 95%. But our trained graders have sensitivity only like 75%. So we look at that papers. We think it probably be the time that we may need something to do in Thailand about the diabetic retinopathy screening in Thailand. So we just contact them. Ask, do you want to validate your model in Thailand? They said, why not? So we collaborate. So instead of having the trained graders to read retinal photos in the middle part, in the lower middle part, we use their AI. AI is in the cloud. So the nurses just take pictures of retinal photos instead of reading, because, well, even though we train them, they're quite, some nurses, they're not quite confident. They have to like refer all those images to be read by the ophthalmologist as well. So sometimes it takes like months to get the result back. But for AI, when you take the retinal pictures, you can upload it into the cloud, and AI in the cloud can read it and send the result back, and you give to the patient right away. And you can recommend referral right away with AI. This is what we are doing in Thailand. Last year, we set up this in like 24 hospitals in Thailand, and we plan to do this increasing by 30% in the next year. I think this is my first presentation. Thank you.
Thanks. These are three remarkable examples of the potential implementation and benefit of AI. And what I want to ask is, when these types of stories get told, it's like, that's fantastic, but each of you must have encountered some significant problem or obstacle in getting from the insight to the action. So I'm wondering if each of you might just reflect on some of the important obstacles that inhibited implementation and how you address them. Do you want to start, Dr. Dagan?
Sure. So yeah, maybe it looks nice in slides from after several years of uphill battle, but even now it still continues to be almost a daily battle to maintain these kind of systems. So for us, as I said, the first challenge was to break that brick wall of the EHR and how to integrate things into the EHR. We did it several times, and we found that it was not effective enough. So first of all, as I said before, we tried to reinvent the wheel and to find different aspects of integrating different, very specific insights. And it was, and the EHR in Israel is a very specific EHR, which exists only in Israel, but I think that the same problem happens in many other places where the EHRs are designed to do one specific thing, and we want to use them in order to do something else and to introduce those insights into the system. And what we found is that, one, it's very hard, and all sorts of IT issues, which it's really hard to comprehend why they're so complicated, because we do things that are pretty complicated, and sometimes like creating a small button in HR is like, it will take a year, and you cannot perceive why. So what we understood is that we have to find a systematic way of breaking that brick wall, and this is why we created CPI. And even with CPI, we understood that we need to start small. So currently this system is integrated into the EHR in several manners. Some of them meant for proactive time, reserved time in which you do proactive care, and some of them very tailored to regular care when you have only a couple of minutes because the patient came in for another reason, and just we want to use the extra 2 minutes that you don't have in order to do something that is important for their preventive care or future health. And we had to compromise a lot about how we wanted to do things that we really integrated into the EHR. So for example, one thing that is still not existent, but is currently in work right now, is to make everything more accessible in a way that will not just present recommendations, but within a click of a button, it will actually create the automatic actions in the EHR to actually create, let's say, a skeleton visit or an encounter that already has all of the different referrals that needs to take place based on the recommendations. And this is something that is much more complicated than create one button, but we settled for that one button in the beginning, and we've been running with that one button for the past couple of years that basically pops all of this, the rest of the system. But currently, we've been working for the past year very hard in creating those automatic actions that I think will make everything much easier for physicians. So I think one major limitation is how you integrate into the EHR and how you find a way to do it in a manner that once you found a way in, it will serve you no matter what the next project will be and the next clinical condition will be. And the second thing was basically acceptance and adherence from physicians, and that was even much harder than breaking the EHR wall. It's really hard to gain trust from people who are dealing with things that are very high stakes and that they are accountable for those things. And at the beginning, each time we spoke to a group of PCPs to basically work with them and show them the different things that we create and get their feedback, because we wanted continuous feedback to really tailor it to their needs. If it was like 60 minutes of a meeting, 30 minutes was venting about why everything is hard with the EHRs and why everything is not like it should be. And then 30 minutes explaining why they don't need what we want to provide them. And because they know how to treat the patients. What, are we coming to tell them that we know better of how they should treat the patients? And it was a very long time until we have the first drafts of actual patient data, which completely changed those meetings. Because at the beginning we only had sketches, like user experience sketches and UI sketches. But once we came with some like first MVPs of that system with actual patient data that those physicians knew because they're their patients. Every meeting started basically with 30 minutes of they can't hear anything, they can't perceive anything they say, they just want to see the gaps that you find because they don't believe them. And they start like digging into the patient's record and say, there's no way I've missed that this patient had an osteoporotic fracture and I did not prescribe treatment. And those are the best PCPs that we have because those are the PCPs that we chose to be our partners for this. So it was really hard for them to perceive that they had like these kinds of gaps in care, and it's for every clinical domain that we tap, and it's for any type of or any PCP that we meet with. So basically, until they saw it in front of their own eyes that this is real and that they need it and that it helps them to save lives, it was really hard to get them to be on board. And it's like egg and a chicken kind of story. How do you get your organization to put a lot of effort and a lot of resources into something that a lot of people say that they don't need? And once it's there, it's spreading like almost like a fire in a very dry field, because then it's a hearsay that basically passes really quickly, and now the demand is much higher, and we get to really increase the number of deployed settings that we have by the week. But I think two main first issues that we've encountered is that EHR brick wall and that acceptance from those who are meant to use that system.
Yeah, I think that's so important. One perceives the notion that through a lot of computational issues and AI, the potential for physicians and other professionals to perceive a loss of authority, legitimacy, and I think that's going to be, one of the obstacles that we see. Thanks very much. Professor Tom Pei.
So I think the work we have been doing is more with the marginalized communities, and as such, the big challenge is one of low resources, low compute, and low data. So the work I mentioned with respect to the youth experiencing homelessness in LA, when we were introduced to the problem, is like, okay, we're going to use social networks and find key influencers, and they will be able to spread the message of HIV prevention. It was never mentioned to us that the networks are themselves not available. So there's decades of literature in computer science about finding key influencers in a network. And so we thought, okay, we can harness that work, except that in reality, after all the initial papers were written, and we said, now let's start excitedly, let's start going to the field and trying to deploy this. Well, there is no social network. So that's when the research begins. And that's where indeed the PhD was to figure out how to sample a social network in order to figure out how to find the key influencers without having to collect the entire data set for social networks. So these are the types of difficulties that we've continuously faced. The other is, of course, low compute. These are organizations that are often not rich enough to get lots of compute cycles, so you have to have frugal computing algorithms that can survive. And so that's the second challenge. Of course, there are organizations that where they are in such dire straits that really they want AI, but there's really there's no need. Sometimes the people at the top will come out and say, yeah, let's meet, let's start discussing, but people at the who are working underneath will say, really, we just need some very basic equipment. I'll give an example from the area of conservation. So we go to a national park, the park managers and so forth, AI, we can do all kinds of good stuff. And the rangers will say, we just need better shoes. That's all we need. We don't need AI. So these sorts of stories, where what I've shown you are partnerships that succeeded, but there have been many that really there's lots of conversations, lots of investment, and in the end, sometimes things haven't worked. So you're absolutely right. What we presented were all the success stories, but there's no, also in academics, there's no venue to publish why we failed and where we failed. So that's also a contribution. That's also the reason only success stories get told.
is very helpful because we will need to study those elements of implementation and where the frictions are in different kinds of social and cultural contexts, as well as political and financial issues. So both of these are really incredibly valuable for us. Dr. Riambumsuk.
Thank you. Well, I think for me, the most challenging of this is to transform the manual workflow into digital workflow, because this is kind of infrastructure. Well, when I show you the picture, well, the above picture of we train like personnel to do the screening, it's definitely manual workflow. The screening didn't connect with everything. It's just standalone screening. Once we like to deploy AI, we need to create a kind of like a digital platform to integrate the cameras. We have like 700 cameras in Thailand, and we'd like to integrate that into the digital platform. And we have different kinds of like hospital information system throughout Thailand. We have to integrate that into digital, the platform that we're creating. So, well, the platform is very beneficial, I think. Except from being infrastructure of using AI, you integrate AI into that platform, right? But you're able to track patients when you refer them. This is very important because even though we train the personnel to do the screening and to refer patients, we don't really know how many patients actually being treated at the tertiary centers. But once we use the digital platform, we are able to track them, how many of them really have treatment at the referral centers. I think the infrastructure is very important, the transformation into digital workflow. Thank you.
I think all three of these examples represent that in order to implement, you have to eventually get outcomes that are really valuable. And all three of these narratives really do that. Let's take some questions from the audience, and also anyone online, please type your question in and we'll get it in the queue. Yes.
So, Aaron Abend, Autoimmune Registry. The practice of medicine has been around for thousands of years. And the understanding of medicine as science has really only been 200 years. Microbiology, really understanding what causes disease. Medical education does not seem to have changed very much, nor has the practice of medicine from the doctor-patient perspective. How much do you think that has to change if we're going to take full advantage of these technologies and get more people to the minimum level of care? Because a lot of these technologies benefit the 1%. And we're not going to get there by continuing to try to scale out doctors spending 15 minutes even or half an hour with a patient. There's just not enough resources. Do you have some solutions for this?
Well, I can take on this question. It's a very good question. Well, actually, while we are doing the study, we also conducted a kind of like a qualitative study. We present the result in the Computer-Human Interaction Conference back in 2020. We also do the interview of patients who receive screening by AI, and we also interview the nurses who conduct the screening by AI. I think they're quite accept of using AI based on the population of Thailand. Maybe because we have the kind of like maybe primary care services in place already. They know about the screening. I think the important thing is we need to communicate. We need to communicate with our students, our patients, that this is a new technology and this is AI. The AI is going to help us. It's not like AI is going to, actually, if you come and have the human grader to grade your photographs, you're going to have the result, but result may be later. But once you have AI is going to help you to get results faster. I think we need to communicate with all the personnel and on the students for education, as you mentioned. I think that's the key of driving this in the future.
So just to add to that wonderful answer, so I entirely agree that with AI, there's always this danger right now that we are only continuing to benefit the 1%. And the whole field, the movement in AI for social impact, AI for social good is indeed to expand the benefits of AI to those who have not benefited from AI towards the more marginalized communities. And there are completely new AI research challenges just because of the lower resource availability in those communities and so on. But as to your question of changing how people get educated, this is true perhaps in medicine. I don't know enough about that, but certainly in AI, that is a requirement because the way I learned AI 30, 40 years ago, roughly still the way we teach AI. It's all methods-based, and if we want people to really focus on interdisciplinary work, then there needs to be quite a different set of topics that people need to be educated on. And really being able to, just understanding how to form these interdisciplinary partnerships and because otherwise all we get taught would be just methods and, all kinds of interesting methods, but that doesn't equip students to go out in the field and do the kind of work that we want done, especially if you're saying how do you benefit people that are beyond the 1% who would normally benefit.
I would also add, with regard to the education part, that it's still really hard to find physicians that speak that language of AI, and it's really important when you try to develop these kinds of solutions to have people who speak this language and also speak the clinical language. And it takes time to change that, but it is changing. We have several efforts in which we try to tackle this problem. So one is we have general annual course for clinicians within Clalit about AI. So when they want to learn about AI, there is like a dedicated course that we provide annually to the physicians, and we try to engage with them and to explain, and like every year, I think the number of applicants grows, and the cumulative number of physicians that start to speak this language and to be able to they have those very good ideas and initiatives that they want to promote, so they get to understand what's possible with the current technology, what's not possible, where are the limitations, where they need to go if they want to start these kinds of projects, and how they need to use these kinds of insights once we provide them. So that's one thing. And the second thing that we also found that for the actual development of these projects, it's like when we put clinicians in the room and data scientists in the room, and we take a year or two to wait for the project to develop, sometimes we find that many projects do not proceed as we wish them to, or we expect them to. And what we found is if we take physicians and train them very high intensity with regards to data science and digital healthcare and product management, then we get to have those people who speak both languages and create those projects which are very fruitful. And we have now a residency program which combines public health and preventive medicine with all of those, it's the classic public health residency that we have for MDs, but now we integrate all of these new things into it. So they learn how to code, and they learn how to create prediction models by hand, and they learn epidemiology, and they learn how to be product managers, and to do all of these things together. And suddenly we have these very powerful individuals that can do very advanced things and speak both languages, and we find that it's very, very helpful for us to promote these kinds of projects. And really, really remarkable MDs come to this residency program. So now we have a pretty good cohort of physicians that help us to basically develop this new age of solutions.
But just one sentence. I think this is a proper time that we may think about putting AI in healthcare or medicine into the medical students' curriculum. I think this may be the right time to do it.
It does strike me that it's not precisely the set of skills that we're teaching to our medical students now. So that's a major reform. Let's go here, and then we'll come back here.
Hi, thank you all for your presentations. You're doing really amazing work. And I guess when we we know from experience that when we start screening, we will obviously increase the number of cases found, and that can bring a burden to the system as well. So I was wondering if you could comment on how that translated in your particular context. For example, when in Israel you start finding increased risk, increased need for tests, increased need for medicines. Same thing for in the case for Thailand, increased needs for ophthalmologists, procedures, etc. So how is that? In your particular context, how did the system receive that, and how did you approach that? Was the health system, were the system involved from the beginning, and the capacity? How was that capacity increased to be able to receive all the amount of increased burden that they would have from these amazing tools that you have built? Thank you.
Go ahead.
Okay, this is a great question. Well, actually, we run a kind of health economic model based on the data that we found. We found that exactly as you said, from the perspective of healthcare provider, when using AI, it's more expensive than using the trained personnel because it's more sensitive. You're going to take a lot of cases come to you. But in fact, if you evaluate in terms of healthcare perspective, the cost of blindness, patients with bilateral blindness, is much more if you use trained human grader instead of AI. If you use AI, you're going to have a less number of patients with bilateral blindness. So we found from our health economic evaluation, I think we need to prepare resources. For example, I mean, the treatment of diabetic macular edema, one of the major causes of blindness from diabetic retinopathy. Instead of refer patients to have treatment at the referral center, we may need to train a general ophthalmologist to do the injection locally at the community hospital. That's maybe one of the key factors that we try to do to limit resources. Yeah, we need to prepare that. Yeah, this is good. Thank you.
So first of all, I completely agree with the thinking about preventive medicine as the more efficient type of medicine and the much more cost efficient. I would also add that prediction models are beautiful in the sense that for preventive care, they provide us a continuous risk. So that basically means that we can gradually titrate our preventive efforts based on the prediction model and just start with the most high-risk patients and then gradually decrease the cutoff for intervention. That means that basically we can have everything continue as normal, and most preventive efforts currently are very broad in nature, right? In Israel, every person between the ages of 50 and 74 needs to undergo screening for colorectal cancer, for example. So those are very broad but efforts, and currently the capacity of the system is tuned for those efforts. But if we want to make sure that those very broad efforts, which sometimes translate to low adherence because they're very broad, are also augmented by prediction models, we can be very careful choosing what cutoff we want for intervention. If we start with like top 1% of patients at risk, and we see that everything holds, and the prediction models basically act as we plan and anticipate them to work, and the system is able to absorb all of the extra patients that now have increased adherence because we target them proactively, because we identify them as high risk, then we can go to 3% and 5% and gradually increase these numbers and gradually increase capacity as we go along because, again, I think everyone recognizes that basically these efforts are the most cost efficient. So we just need to gradually challenge the system, but for the first time, I think prediction models allow us to do that, as opposed to the very broad set of criteria of yes, no, for most preventive efforts currently.
So just a brief comment on that. All our efforts have really been focused on limited resource settings. And then the question becomes one of how do you optimize those limited resources? So I talked about the bandit models and so forth. And so those are all efforts to say we have limited resources to offer interventions on beneficiaries. And so the question is which beneficiary should receive those interventions because the resources are basically limited. And the AI approach is using past data to make predictions on where the intervention resources would be most effective. And so AI could be used as a way of trying to figure out how to optimize our limited resources in this way.
Thank you very much.
Thank you for sharing wonderful real-world applications of AI in healthcare prediction and social network, community engagement, and diabetic retinopathy risk screening. So my question is that can you comment on the opportunities and the challenge to build a general purpose longevity, healthy longevity system, anti-aging system for AI-based, so that we can reduce the healthcare burden, and can the insurance industry will cover this kind of endeavors?
So you mean how to build a system, right?
A system.
This is what we are doing in Thailand. So once we deploy it, before we deploy the AI for screening, for the whole country, we need to set up we set a Chrome-based application, which we call the digital platform, and we integrated AI into that platform. So it means, for example, in the screening site, you just turn on the web browser, and then you just key in the username and password, and then you get into your site. And then when patient came, you just turn on the camera and take retinal pictures, and then you use that platform to upload the photos into the cloud. And then when the AI do the analysis, the results going to send to you right away. You're going to give to patients right away. And with this platform, we also use it for the retinal specialists in the tertiary care. They overread the result of AI without knowing the result of AI reading. So we actually didn't trust the AI 100%. We do the overreading. So if the reading by the retinal specialist is similar to the same as AI, we do referral. If it's not, we're going to do the adjudication. And we use this system also for the tertiary care, for track patients. This is what we are doing, a kind of infrastructure, the system.
Can you expand the system to a general purpose, including other parameters for predictive health?
Is it okay that we, because of limited time, maybe give opportunities for other?
We're going to have to move more quickly with the questions. So let's take the next one.
Excellent. Thank you to the panelists for a fantastic conversation. I have two questions, and I'll keep them brief. For Dr. Dagan, but absolutely would love to hear the experiences and opinions of the rest of the panel. When we think about AI, it can often be a black box, and that could be a challenge, especially when you think about adoption from physicians. So how do you address that challenge in your platform in terms of what features led the model to suggest XYZ?
It's a really great question, and I think that we've learned that the amount of explainability depends on the type of use that you intend for the model. So if the model is for some extra benefit that we want to provide, but that's not a highly limited resource. So if, for example, in the beginning of the COVID pandemic, we created a model to identify high-risk patients so that physicians would be able to contact them, physicians and nurses, contact them in the very first weeks of the pandemic and alert them that they might be of high risk and they should be careful, and this is how they need to use the digital manners of how to contact with the clinic, because back then it was much less accessible, or much less, I'd say, broadly spread as it is today. And for that model, it could have been a black box, because we basically had to provide some insights why is this patient probably is at high risk, but if a physician wanted to basically contact another patient, they could, so it wasn't very sensitive. In other aspects, when we have some limited resource that we want to allocate, and it's a sensitive resource, and we use prediction models in order to stratify the population into those who are eligible to receive it and those who are not eligible, that needs to be completely transparent to the point of almost manual calculation. So it should have to be something that if, for example, a physician saw that a certain clinical condition that goes into the model is not recorded well in the patient's record, but they know that this patient has this condition, they can override the model and explain how the risk changes. So it really, really depends on the type of use. And we see that for uses that are not really sensitive, they're very efficient because we need to prioritize somehow, but they're not highly sensitive because the resource is something that could be really allocated easily to someone else. Then we can tend more to use black box models, and then we have the added performance of black box models. But when it's very, very sensitive, we have to compromise sometimes for slightly less accurate performance, but much, much more explainability. So it's like really one use case at a time.
Understood.
Thank you. Thank you.
And the second question, quickly, when we think about machine learning models, artificial intelligence as products, and their life cycle, how do you address the concern of the bias they introduce into reinforcing certain pathways and behaviors by physicians?
So I think maybe this is the biggest challenge that we're currently facing. Less for the models that we develop internally, because basically it's based on our own data, but when we think about all of the models and tools and solutions that are out there, and their number is increasing exponentially, for the first time, I think that healthcare organizations face the problem of how to be able to do some self-regulation of what tools they enter into their homes. Because until now, for pharmaceutical agents, for medical devices, we completely relied on FDA approvals and other types of approvals. But now, for the first time, the fact that some model acted very well, performed very well in a different setting, almost says nothing about how this model will perform in your setting and what biases will go into the performance of this model, because it's so highly related to the data that goes into it. So for the first time, as a healthcare organization, we face the problem of how do we deal with self-regulation? How do we evaluate the biases of these models, and how do we choose which models we can integrate into our system and for our patients? And this is a very complicated challenge that I suspect will need to take more time to.
Yeah, for deployment in Thailand, we address bias by having over-reading by retinal specialists. Yeah, that's what we do.
That makes sense. Thank you.
Thanks. We have about 5 more minutes, so a short question, and our speakers will be relatively brief also.
Chesley here at Noah Pasan. I'm wondering, taking a higher level, what lessons have you learned in your deployments and implementations that the U.S. can adopt, since, in my belief, we're much slower, given that in my experience in healthcare now and down in Brazil, we adopt much faster. Just high level, what things can we learn here to speed up those deployments?
Lessons in deployment.
I guess directly for Noah and Paisan, since they're outside and you're working, but you're happy to answer as well. But
well, yeah, I can do it. Actually, the lesson I learned is that you cannot be like too optimistic about AI, well, because in the real world, well, even though the accuracy for AI is very good in published papers, you have to take a look, because most of the published papers, they're kind of doing kind of like internal validation. They validation the AI model in the internal data set, not external data set. But in the real world, I find that, well, you still see a lot of like false positive cases, especially when you have patients with cataract. You cannot take the pictures of retina quite clearly. So, well, all those images, the retinal specialists or ophthalmologists tend to be able to read those images, but AI may not be able to read. So you may be a little bit not too optimistic about AI.
I guess from my perspective, key here is really partnerships from beginning to end in deploying things. So if you take a deployment that was done outside, I'm sure if it was successful, that meant that they really took the local context into account in how they built the model. And there may be certain quirks, certain ways the data was collected, et cetera, that you can't just take that model as is and apply it here. So that means that in taking it to a new context, really understanding things on the ground, really taking that local context into account. And so from my perspective, it's always been one of beginning to end, really focusing on the partnership and taking feedback of the local partners into account in doing any deployment is crucial.
I'll build on this answer because it really correlates well with what I wanted to say. I think for us, the big difference is that Clalit, as a health organization, decided that strategically they want to, from like many years ago, they want to invest in data and in people who know what to do with this data. And that is not natural for, I think, many healthcare organizations, because that means like put some money on people who develop these kinds of things and learn to speak this language. And because this is so tailored to the local data, and you have to have people, I think, inside these organizations that know how to speak that language and to want, and they are basically eager to promote these kinds of projects, that makes all the difference. And I think we were lucky enough that our managers and the policymakers in Clalit decided many years ago to start these, what was started as the Clalit Research Institute and grow into what we now call Clalit Innovation, which is just under the Clalit CEO and gets basically high priority to promote these kinds of things. And that makes a big difference for us.
Thank you.
I hate to end this here, but I just want to reflect on what I just heard, that in a way there's the science and there's a great deal of consensus and understanding, but it's the process of implementation requires an incredibly sophisticated understanding of organizations, culture, local politics, and circumstance if it's going to be successful. And the last thing I would say is, if we don't find a way for AI to really serve the general human good and reduce health disparities, then I think in and of itself it will fail. So that becomes a kind of ethical or moral principle that I think underlies the work that you all are doing so brilliantly. So I really want to thank our panelists. I think this was just a great discussion.